collaborative team-based vision of the patient's medical home is foundation to the work that Artem does, and he also leads partnerships and joint advocacy work, including allied efforts with Canadian Nursing Association, Canadian Home Care, the Canadian Association of Social Workers, and many more. Over to you, Artem.
Thank you very much, and thanks to everyone for joining. It's a real honor to be the inaugural speaker, as Ivy has called me. But it's a real pleasure to be able to speak to this. And as Dale has mentioned, much of my work is really focused around building bridges and building coalitions, so that the work that we do together has maximum possibility to affect positive change. And I really found that the patient's medical home vision is a fantastic foundation to build such work around and to bring people around. So I'm quite excited that I get to speak to you about it today. I am now going to try to, oh, there we go. Just learning how to do slides again. So the patient's medical home has been the vision that the CFPC has been pushing and advocating for since 2011, actually. An earlier version was released in 2009, but since 2011, this has been our official policy that really stressed the importance of interprofessional team-based care and those interprofessional collaborative practices providing comprehensive continuous care to their communities. It's been a real pleasure to work on this with multiple allied health and other partner organizations. So the current version of the vision that was issued in 2020 was endorsed by multiple organizations, as I mentioned, the Nurses Association, the Home Care Association, the social workers, and we constantly are looking to bring more people behind the vision, because we think it's a really strong expression of what team-based care can be. And as Ivy has mentioned, as we are all sort of trying to understand how it looks like in practice, it's really exciting that since its inception in 2011, there's been quite a lot of progress that we can see in terms of how this vision is becoming reality. So just a little bit about the vision itself. I was asked to presume that people here know about it, but just to cover some basics, this is little house graphics that discusses the basically 10 key aspects of what makes a patient's medical home. And in my very high-tech PowerPoint skills, I have highlighted the two most relevant ones. One, the fact that the education is a core component of a patient's medical home. So it has a strong relevance to the work of the Team Primary Care Grant, as we look at how different health professionals, including family doctors, are trained. And the other is that it is inherently team-based. There is no patient's medical home without a strong team. So it's really great that we have a variety of stakeholders around the grant and around this table and around many patient's medical home tables. We do have a fairly solid, robust evidence base behind the efficacy of the patient's medical home. We know that both patients and physicians, as well as other health providers, prefer this kind of vision as opposed to sort of a more siloed traditional way to practice. We know that it has great numbers in terms of improved continuity of care, better preventive care, more comprehensive level of services being offered. If in high functioning patients' medical homes, there is evidence in reduced reliance on emergency room use, as patients are able to access the care they need within the community without having to escalate to sort of higher acuity level of care. Finally, as you know, any conversation with government inevitably shifts to how much it costs. And what we've seen in the evidence is that even though some implementation of patient's medical home does come with an increased investment in primary care, what it does, as indicated by that bullet point about reduced reliance on ER, it sort of shifts the pressure away from other sets of and levels of the healthcare system, thus saving the system money. One of the most famous examples of the efficacy and the cost-saving power of PMH that's been demonstrated in Alberta in I believe 2015 or 16, where two PMH level practices have done an analysis of their system costs over 10 years. And it was found that despite increased investments into primary care level, overall, these two practices were able to affect around $120 million in savings over 10 years for the system. As I mentioned in my sort of little house graphic, the patient's medical home is a fantastic site for training, both in terms of family medicine residency standards, but also for many other health professionals, because it really offers exposure to a broad variety of the kinds of care that are being provided, and the very close integration into the community, both sort of within the healthcare system and within the patient's medical home, as different health professionals work together for sort of the common good. And we do know that when we ask the family medicine graduates and residents in terms of the kind of practice that they would like to practice in, a vast majority of them do say that the patient's medical home is a very likely target for them. Because patient's medical home is quite amazing, and as you can tell by my start of the presentation, we do push it fairly hard with our government representatives when we do our advocacy on the national level, and it has been quite sort of positive as a solution to the current crisis that we are seeing in terms of what we see quite a lot of right now is the fact that many health professionals, especially in primary care, do feel overburdened. There is too much demand, too much complexity. There is an excessive administrative burden. And at this time, like at no point before, the patient's medical home comes in as a solution. And what we want to see is more of it integrated throughout Canada. And thanks to some investments that have been made, and some of the following speakers, some of whom I did have the pleasure of working with, and I think are fantastic presenters. So you're in for quite a presentation throughout this lunch hour. We do see quite a bit of implementation on a provincial level. It varies because it really depends how different provinces and when different provinces started implementing some of this stuff. There was a significant sort of envelope of funding available between 2000 and 2007 from federal government to the provinces, and some of the bigger provinces used that to get started on some of their work. There we go. Yeah. So we see some of things like the FHTs in Ontario or Traitement de Famille in Quebec were started during that time. And some of the provinces, like PEI, are only starting on their patient's medical home journey now, but in doing so, they're able to integrate so many lessons from the past, and are arguably doing it in a way that leads the country in sort of the preciseness and the robustness of its implementation. So it's a very exciting time for interprofessional collaborative practices and the patient's medical home, because there is so much attention to health. And of course, with the new federal package of funding that was just recently announced, as you can see by a very pensive photo of Minister Duclos here. So one of the shared priority areas that was announced with the federal funding, with a $25 billion investment over 10 years, is the family health services. So that kind of captures that primary care level. And to add to that, the recently released report from the Standing Committee on Health also lists many recommendations to the federal government in terms of, in addition to their very heavy emphasis on international recruitment, there's also a very solid focus on reducing administrative burden, building up those community-based interprofessional teams, and making sure that actual progress takes place to create a more sustainable, more effective system that people can enter and stay in without getting burnt out. So, of course, Team Primary Care has been natural alignment, and we've been working closely with both IVs, who are both fantastic leaders. And the alignment that we have in terms of the sort of the reform that's taking place in education is, for us, when we advocate on the family practice reform that takes place, to make sure that policymakers understand that in order for those new graduates to make the best use of the skills that they learn in these new improved settings, they have to be able to come in and apply these skills in practice in where they're able to work in those settings. So
Great.
it's,
oh, sorry,
almost done, Dale. 40 seconds left on my clock here. And finally, as one of the key sort of tangible items and tools that we're developing as part of this higher level project, we are working on a self-assessment tool, which is basically a very robust questionnaire that practices can take to check how well they are aligned with the vision of the patient's medical home, and what are some of the areas that they can step up in order to become even more aligned. So there is great interest in both practice and government area for this tool, and we look forward to piloting it as it's nearing completion as part of Team Primary Care project, and applying all of the feedback that we will get from it. And that is it. 10:04. Boom.
Thank you very much. We started a little late, so sorry I was pushing you along. So if you stop share and Trina can share her screen. Our next speaker is from Prince Edward Island. Trina Stewart knows the Maritimes well. She's a graduate of Memorial University in Newfoundland and completed her family medicine residency at the Dalhousie University Fredericton site, and is now practicing comprehensive primary care in Summerside, Prince Edward Island. In addition to her practice, she is the curriculum coordinator for the Dal Family Medical Site in PEI. And she's a physician advisor for primary care renewal for Health Prince Edward Island, and also the PEI representative for the Canadian College of Family Physicians continued CPD program, and is past president of the Medical Society of Prince Edward Island. Trina, over to you.
Hi, everybody. Can you hear me okay?
Yes, we can. Thank you.
Okay, perfect. So I am sharing my screen. I know you can see my slides along the side, but for some reason I've got a bar over the top, so I can't do my proper slideshow. It looks like we're having some technological issues today, but anyway. So I'm the physician advisor for primary care renewal on PEI, and I've been in that position for going on 2 years now. I'm going to have a hard time moving my slides over though here. So I wanted to bring your attention to the document that kind of brought us to where we are today. It's called the Primary Care Roadmap, and it's a strategic document that you can access. If you Google PEI Primary Care Roadmap, you'll find it. It's for public consumption. And it basically describes kind of where we were, where we want to go, and how we kind of got to this process of expanding team-based collaborative care across PEI, because it did exist in a former iteration, just not as robust as it is now. And I think it really speaks to the initiatives and why we feel we need to go this way. I think we all know that access to care is an issue, and we all want to improve that. We want to innovate. We want to leverage virtual care and integrate and coordinate care for our patients in a team-based way. So the primary care roadmap, the principles upon which it's based are that it's patient-focused and centered, that it's delivered through collaborative teams, leveraging the provincial community health record, which we are launching as we speak, a provincialized EMR solution across the province. Eventually, everyone will be on it, family physicians, specialists, community mental health. You know, it's going to really integrate us. We'll all have access to the same chart. So that's really an enabler for us. Obviously, leveraging virtual care platforms and obviously using a community health approach. So how did we get here? The primary care, we had a lot of visioning. We had to think about governance. We had to think about work plans. There's been a lot of background. So when I started in this role, probably like early fall of 2021, we were pulling all of these pieces together. They didn't really exist at that point. And so we also had kind of a short list of maybe some potential teams at that point. because really our mandate was to get some teams up and running across the province. And ideally, we wanted them to self-identify, because what we've seen and what kind of makes sense is that if people identify that they want to work together, they will likely work together better. And that's really, really important. So this is kind of our governance structure, just so you can see how we kind of set things up. And our executive committee would be our provincial colleagues. This is a bilateral initiative. So we basically have our health authority and our provincial government Department of Health working together, and we all sit together. So the executive committee is our chief medical officer, our deputy minister of health, who co-chair. And our steering committee would include other people like me, along with people representing space and infrastructure, our tech people, because the IT part of it is so critical. So we bring in kind of those higher levels, and then we have a larger implementation team, which brings in even more community engagement. We have a little offshoot of that, which is our project management team, and then all of our working groups that are actually into the nitty-gritty, kind of pulling everything together, because as you can imagine, there's a number of balls in the air when you're trying to pull teams together. They may or may not necessarily be co-located. They may not have enough space. They may not have enough staff, which, you know, nobody has enough staff right now, or the right cohort of staff. So that's to give you a bit of a snapshot. And this is a really busy slide, but it kind of gives you an idea of how everything integrates through our health PEI process and who's responsible to who and that kind of thing. So very, very busy, but I thought it would give you a little bit of a snapshot of how complex it actually is. So, you know, the transformation of health services going from, you know, physicians basically working alone together to trying to teach them how to be contributing members and valuable members of a team, and actually embracing other allied health in their scopes of practice, and allowing all allied health and feeling comfortable with them working full scope. It's a bit of a continuum, a bit of a process, as you can imagine. It's not how physicians are traditionally used to working. So then, you know, we get from the I take care of these patients, hopefully, to we take care of these patients within our patient medical homes and neighborhoods. That's the ultimate North Star. So there's a bit of a phase rollout. I have a little bit of a visual of this slide because it's all over the place. You know, like initially we have some teams that the EMR is implemented, some that it's not, some that engage later. Like this is all kind of willy-nilly, but once we have a team locked down that they're committed, we start with a team and practice development. And I guess this would be the training component. I know that Dale is hoping that we would all kind of talk about a little bit today about, and, you know, we're doing this on the ground as we speak. Ideally, you know, we need to be incorporating training at the grassroots level, you know, at undergrad level, postgrad level. But we have, you know, trained professionals that are ready to go now that have been working in clinical situations or admin situations for a really long time, but they haven't necessarily worked in this fashion. So how do we make that happen for them? How do we make it successful? How do we make these teams know how to work together better? So how we're doing it is that we have embedded practice facilitation into
New Brunswick, or I mean British Columbia got this figure.
Sorry, can you please mute? So we've embedded practice facilitation. So the minute a team is launched, so to speak, they've signed a bilateral commitment document with Health PEI. So Health PEI has committed to them and they've committed to Health PEI. We right away start them with practice facilitation, and we have hired practice facilitators out of Alberta. So we're doing a lot of virtual work with them. And these would be the things that they're working through with the teams. I mean, the first question they ask the teams is, do you have a QI committee? And 100% the answer has been no so far, which is kind of crazy in the year 2023. but everyone having different ways of documenting, some having computer-based EMR, some still using paper. Up until recently, it was very difficult to have, meaningful QI. So that's been something that has really been changing the landscape for our teams, and it's what's moving our teams forward in the most valuable and meaningful way, in my opinion. And part of it is, through defining roles, making sure we've got clarity of roles and responsibilities, defining what leadership means for all parties involved, knowing the value of every team member and what they bring to patients, patient care, and the team itself. So, the key observations to date are that physicians have been working along together. They're members of teams, but at the end of the day, they really feel on their own, and have taken all that responsibility onto themselves, which has become too onerous. Physicians are doing non-physician work. There's definitely, in a patient medical home setting, a role for a team leader coordinator, somebody that can help with getting the QI meetings set up, helping with getting the little mini projects set up within the teams, knowing how to coordinate the various members of the team. It can't be the physician doing that. And I would argue anybody doing patient-facing work should not be responsible for that, because they really don't have the time. The referral model to access other allied health and providers is definitely a barrier. So wherever we can get rid of the referral model and having robust front-end admin systems set up so that those people are well-trained to know how do you direct the inquiries of the patients to the correct person at the correct time. Is critical. Obviously, no formal QI structures really were in place for anybody. And the established collaborative relationships that existed in our team-based models that, were kind of set up years ago, and with the first kick at the can at team-based collaborative care and PEI, they've moved forward more quickly than those of us that have been the traditional fee-for-service practices that have our medical office assistant and ourselves, who basically are the be-all end-all for everybody all the time. So it's taking longer for us to learn how do we move that team forward, as opposed to the ones that are already in a team. So, the PMH is part of the bigger picture. This is the patient medical neighborhood. I think it's really important to note that you really have to understand the population needs of your community, like what actually do you need and what makes sense for your patient medical home. It may not make sense for me to have a physiotherapist in my clinic because of the population that I'm serving. Having said that, it may make sense for 2 of the PMHs in our locale to share one through our network, right? So, you really have to have that understanding. And, challenges and lessons that we're learning, and not necessarily all learned, but, the evaluation framework that we just finalized is super complex. I think it's really important to measure what we're doing, and for everybody to kind of understand if what we're doing is actually accomplishing what we set out for it to accomplish. Physician compensation in the patient medical home. We're seeing, here in PEI, we've got fee-for-service contract and salaried options for physicians. Blended obviously is looking best. It must account for the admin work. We have a consultant looking at that right now. I actually have a meeting tomorrow. So I feel like there's definitely open ears to talk about what this needs to look like in order to try to keep people in office-based medicine, family medicine. What I worry about is more and more people are going to leave to do episodic care, and that is happening on PEI because of the inequities. And I really think we need to put the value back into family medicine and the importance of continuity and community-based community office-based medicine. Panel sizes, they're always like, how do you judge how many patients should we be seeing, and what's an overall panel size look like? I think it needs to be judged based on the team and what the configuration of your team looks like, and that is yet to be defined, in my opinion. And again, we have a consultant that we're planning to have helped us with that. The HHR, human health resources, is a huge issue. Hiring practices are really not relevant to modern day, particularly on PEI. Nursing contracts are difficult because there's preference for PEI. You can't broaden the reach, have a lot of competitive advantage. NPs carry their own lesser panel on their own care, which is very helpful. But what we've noticed is that they can leave a practice within a couple of weeks of notice. That's hard for the patients and for the clinic. So,
Trina, can you just wrap up pretty quickly? Sorry, we started late. So
nearly done, Dale.
Perfect, thank you.
So private versus government employees, and what I mean by that is, you know, sometimes you have people, a landlord has hired the staff for the clinic. Sometimes it's health BI and there's no wage parity, there's no credentialing parity, and that's becoming more of an issue. Yeah, and physician burnout is real. The admin burden is real. There's a lot of things that need to happen to kind of address that. Right now in PEI, the challenge, we have a provincial election happening on April the 3rd. We also have a proposed MUN UPEI medical school, which our government has committed to, which thankfully I'm being invited to those meetings to talk about what the Wellness Center, which will be a multidisciplinary teaching and service type of center on the campus. So, you know, I think there is definitely the sense that this is really important, and that it is the way of the future. And as we're training our students coming up through that, this is how they need to be trained. But we're still figuring out the on the ground pieces for those of us that have been working in the field for a long time, and what that needs to look like in order for us to work well together and maximize what each other does with our patients.
Thank you, Trina. Much appreciated. We're going to move to Alberta now and hear from a province that has had primary care networks in place for some time. The Accelerating Change Transformation Team, also known as ACT, is funded by a grant from the Government of Alberta and deployed through the Alberta Medical Association. Its core purpose is to improve the patient's medical home and transitions of care in the health neighborhood. And its mandate is to translate complex system change and improvement initiatives into actionable steps to improve patient care. The change management team provides strategic advice, develops training tools, and works with clinical leaders, primary care networks, and health system partners. Lori Choma and Angie Johnson are with ACT. Angie leads the operations and strategic alignment portfolio, and Lori leads the care coordination project. Over to you two.
Hopefully everybody can see and hear me okay. You'll give me a wave if you can't, Dale.
All good. Thanks, Angie.
Great. It's really great to be here, and really neat to hear where other provinces are at and where other groups are at. So happy to contribute a little bit. And I agree with so much of what's already been shared. So many lessons learned that are the same here in Alberta. I guess the environment is very much the same. Physician burnout is quite real, and it's required us to kind of step back to say, how are we going to do this differently? How do we continue to move ahead on the patient's medical home despite these real life challenges that clinics are facing, that Albertans are facing? And so, you know, you'll hear today a few slides on how we are doing this, but to be really fair, we are shifting on the fly all the time. We have to adjust how we meet our physicians, how we meet our other providers that are part of the care team. And this is our best attempt today. So let's see if I can advance the slides. Our guiding light has always been the CFPC vision for primary care too, and it's been a number of years that we have adapted it, over 10 years now, to this model you see on the right. And the way we teach this to physicians and teams is we say, here's the vision on the left side, and here's how you might go about doing it. So we call these the implementation elements. And we do that in an effort to become more tangible and more concrete for our end users. They are are not, equipped or given the time to often sit around and interpret vision. And so this is our best attempt to try and help them do that. And it's really how we teach and how we link any key provincial initiatives that sort of come towards clinics that are meant to reach clinics. And you'll see an example of that here on the next slide. We built this sort of map, if you like, this journey to indicate how somebody might ideally travel towards becoming a patient's medical home. So we're at the clinic level. So we need those engaged leaders first. We need, a place and a commitment to quality improvement. I've heard other groups mention that as well. Panel and continuity, we really have not seen much success in the progression towards becoming a patient's medical home if a clinic is not willing to or is unable to have good paneling processes and some rigor around repeating those things often. Team-based care factors in tremendously because, as we've heard, it's not the future for physicians to be doing all of the work. It has to be shared among many team members and at the right scope. Organized evidence-based care. This is a great way of making sure that the clinical work is founded on the evidence. And it's frankly what we find attracts a lot of our clinical people into this model. Patient-centered interactions, really changing it to what matters to patients, what matters to their family. And that allows us to make sure we're being relevant in providing care to what matters to patients. And then, of course, access. We can't do those wonderful things that people talked about, like saving the system costs, like reducing ER utilization, if we don't actually have access into a clinic. If the wait times are too long, patients will have to go elsewhere. And then we'll see more of that episodic care as others have mentioned. And then, of course, the cherry on the top is really, how do we coordinate care when a patient has to travel outside of the patient's medical home, outside of the clinic? And so there are a number of ways that could happen. And we think all of that is really ultimately aimed towards progressing towards becoming maturing to a more robust patient's medical home with the right processes, the right people delivering the care. Now, this is an ideal journey. We know very well that clinics may not be able to travel this ideal path. And so we're very willing to work with people along the way. Where they enter the system, where they enter this path doesn't have to be a prescription, but we know that once somebody's in, then we have to take them back to those basics. So what you'll see along the way here, and Lori, you might like to chime in case I'm missing a key message here, but what we've done along the way here in the bolded font, you can see some specific initiatives that are meant to help improve this specific implementation element on that diagram. So, and usually where ACT can have an impact is if we're developing specific tools to help a clinic in that specific initiative. So you'll hear about that in just a few moments. Lori, any key message that you wanted to land here with this one?
Nope, sounds great, Angie.
One of the things we know about in Alberta, and I would suspect it's probably pretty transferable to lots of other places, is this idea of the Rogers diffusion of innovation curve, and the actual research we have in Alberta tells us that there are lots of great ideas, lots of good initiatives, and like most innovations, they are susceptible to not spreading and scaling. And the marketing material in general would tell us that if something is going to be successful, it has to cross that valley of death. Pretty easy to get the innovators interested, and the early adopters, they're quite interested as well. They just need a little extra hand. But the early majority and the later majority are more hesitant, and they will need other things than the innovators do. And so our current focus is to build our tools and our training to attract the majority. If we want initiatives to scale, we have to reach that audience. We have to do different things to reach that audience. And so this is a bit of a guiding light for us, as the PMH always has and will be, in terms of how we, I suppose, customize our materials so that we're reaching the people that we need to adopt these various initiatives and practices. So just an animated slide to show you how ACT works. And just to be really clear for folks, the ACT team we're about 50 people, and we are embedded inside the Alberta Medical Association. We're one of the branches inside the AMA, and we are not funded by the AMA. We are grant funded. And it's always been our focus to be quality improvement oriented, to be change management focused. And we've been able to distill what we do, our services, into a few key things. And so the ones that have the stars beside them, Lori will give you a little bit of information, but it's not unlike the ways other people already here today have talked. It's important for us to connect with specific groups or networks in that lower right-hand corner. We develop training, and it's important for us to develop tools that are practical for our end users. Those other two middle sections that you can see are another way for us to interact with system leaders. Because if, the change management literature would tell us that if we want to be successful in spreading and scaling, we definitely need buy-in from the ground, from the field, but we also need buy-in from leaders to support these things. And heck, maybe even in the most ideal world, get some money put behind these things in order to help them scale. So this is ACT in a nutshell right here that we wanted to share with you of the how we do our work. Over to you, Lori.
Thanks, Angie. So we are proud to say that we have a pyramid scheme for how we do this work. And like Angie showed in the last slide, we work strategically from the provincial level through zone levels and into primary care networks. And it's those primary care networks that actually have the funding to fund the multidisciplinary team members that are within physician and within the patient's medical homes in Alberta. And so this pyramid shows it from an implementation perspective and taking us right down to that clinic level support. So I'll just bring your attention to the arrow there, that green layer that shows that support for change at the coalface, where we have practice facilitators and physician champions leading the change. And many of our tools, resources, and networks and training are aimed at this level. And so it's really at this level that we get that interface with the multidisciplinary team and increasing team-based care. So we do have a strong focus here on physician champions and practice facilitators as our primary change agents. And that's largely from some of the research, and Angie talked earlier about the diffusion of innovation and getting into that early majority and late majority, is that to change the physician practice, the physicians need to hear from their peers. Next slide, please, Angie. So this is our change agent blueprint, and it helps us with our thinking around the support of those change agents. And so again, we don't own the resources, we don't own those MDT members, nor do we own the change champions themselves. We work primarily through influence. So this is a slide of how we apply our blueprint specifically to the practice facilitators, those who actually facilitate how those changes happen in the clinics. And two places where we do intersect with multidisciplinary teams is at that develop level. So we do have on-demand training for a panel management role, a really important role in the patient's medical home. We have training around clinical improvement initiatives, and it's open to MDT members, although not focused at that level. And actually, our two most recent training offerings, when we ran our analytics, we saw that over half of our uptake was actually from those MDT members. So we know that there is a strong desire to help with that change and help with those clinical changes from that group. Secondly is around the deployment. Practice facilitators and physician champions are provided with change packages. Those are our change tools, our version of them. And they describe clinical change in a focus area. So how to leverage the team is always a part of this. Next slide, please, Angie. So this is just a quick snapshot of our current offering of change packages as seen on our website. They all align to the pillars of the patient medical home, but they guide clinics through the evidence-informed changes. There's small incremental steps of change, which we know is what that early majority needs, what we need to get the work to scale. And all of these change packages, they have these repeatable, what we call high impact changes. And each one of them has an high impact change around the element of team-based care. And so it's with this approach, the learning for the MDT team is through the doing. So it's through the actual quality improvement work that the team is built and that the team changes. So we have the team with the help of the practice facilitator to define the problem around a focus area. Like I mentioned, they're focused around the PMH pillars. So it's the team that defines the problem, solves the problem, develops new processes with the support of a practice facilitator and the support of what's found in these packages. So we really aim to look at who could do the work in each clinical context and trying to really flatten the hierarchy within clinics. Next slide, please, Angie. I think it's our last one. We just wanted to show you a couple of examples of our tools. So the first one there, we have some team task tools. It's something that's found through all of the change packages, where we have several of those suggested practices that are broken down into those small incremental changes. And the facilitator takes the team through, who could do the work, who can and who will do the work, and then who's cross-trained in the work, and then who's eventually responsible for doing that work. We also coach teams, or we coach practice facilitators to coach teams to map their processes. So we have them do a before and after snapshot, and we really challenge teams to see how they can decrease the steps that the physician is involved in and increase the steps from the multidisciplinary team members. So yeah, while we don't work directly supporting the multidisciplinary team work, what we do work is we support the teams and support the change resources with the changes directly in the patient's medical home.
Thank you, Lori and Angie. Much appreciated. Our next speaker is Eileen Patterson, and she's a member of the Health Innovation Group. And Eileen has served multiple roles. She started as one of the leads of the Tabor Integrated Primary Care Project, which probably many of you have heard of. It was an early adopter of interprofessional teamwork. She's been enrolled to Vice President of Quality Improvement for Health Quality Ontario. She's led patient medical home innovations across Canada in 9 provinces and 3 states in the US. And with a background in coalition building and leadership development and quality improvement, Eileen co-led the development of the College of Family Physicians of Canada's document, The Case for Practice Facilitation Within Primary Care, and Advocacy Guide. Over to you, Eileen.
Thanks, Dale. Thank you for that introduction. I'm happy to be here to share the model that Health Innovation Group uses to advance collaborative primary care teams in Canada. And I'll give you a few practical examples as well. First, just a little bit of context. Arvel Balanline and I co-founded Health Innovation Group 5 years ago. Arvel is an innovative and award-winning nurse leader. Our goal is to advance patients' medical home in practical ways and show how the principles of improvement can be adapted to different models of delivery. As an organization, Health Innovation Group has been advancing collaborative team approaches in 7 provinces, both in English and in French. We typically work through virtual and in-person collaboratives. Those are group team processes that take the journey together with teams and health system leaders for improvements that achieve a shift from a group of individual providers towards the integrated teams that deliver a comprehensive level of care, including a key tool, the new integrated and interdisciplinary care planning tool and processes. So we base our work, as many of you do, on these College of Family Physicians of Canada documents, the 2019 New Vision for Canada, Patient's Medical Home, and the 2020 Case for Practice Facilitation. This combo outlines what to change towards and how to change it. So the image on the right is from the case for practice facilitation. It's the change agent process that accelerates improvement up to 3 times faster than when primary care teams work without change agent support. And it really leads to better quadruple aim results for patients, providers, populations, better funder value, and more for better equity also. So we work with teams to help them to get arranged and organized to support the needs of the patient population that they serve. So they're guided to embed the proven teamwork behaviors that achieve evidence-based comprehensive care. So to get even more practical, we organize around 8 high-impact changes to achieve the patient's medical home level of care. And each one has a workbook that goes along with it to make it very practical. So that includes continuous quality improvement. It includes panel, understanding your panel, access and continuity, clinic flow, panel management, person-centered interactions, coordinated care with seamless transitions, and all of this achieved through new levels of teams and teamwork. So there are 7 drivers of teamwork.
Eileen, you went on mute.
Yeah.
Oh, have I been muted the whole time?
No. Just
I just started. Thank you so much. Okay. So there are 7 drivers of teamwork, or the 7 C's. And so we use these to get people thinking about their strengths and opportunities for improvement. These were developed by Dr. Eduardo Salas. He's the most published team scientist in the world, and he works with leading organizations such as NASA and Vermont Oxford Network. So this includes capability. Do we have the right people with the right mix of knowledge, skills, and attitudes? Cooperation. Do they have the right attitudes and willingness? Coordination. Are they demonstrating teamwork behaviors? Communication. Is it effective both internally and externally? Cognition. Is there a shared understanding of the work, of the priorities, the roles, and the clinic vision? And coaching. Do the leaders demonstrate leadership behaviors? And most importantly, are there favorable conditions for teams? That's really critical as well. Just moving. Okay. I seem to have a mouse problem, but I'm going to be just fine. So we also, we organize and support the teams using actually a series. So we take them through, in order to accomplish the work, then we take them through why teams and teamwork matters. We take them through looking at the 7 C's of teamwork that I just covered. We also look at the 10 things that teams do, highly effective teams do, think, and feel. And so that is critically important. They design the interdisciplinary teams for impact, and they establish shared mental models for psychological safety, provide patient-centered and culturally appropriate care. And then we dive into the quality improvement team tools for capacity building. So each of these modules at the end has a call to action with practical tools and resources, so teams can measurably improve and enhance their patient care delivery. So I'm showing you a quick view of the 7 C's team tools that we organize to improve each of the drivers of teamwork. Each one is uniquely valuable and has a specific purpose, can be adapted to teams for their context and needs. And I'm just going to show you a couple of quick examples of those. So on the top left is a tool to build shared mental models with teams, or to build their the perspective. So from the 7C terminology, it builds cognition. It guides the teams to clarify the goals, the reasons that they are working on each of those goals, and how they want to approach things. On the bottom left is the patient's medical home self-assessment tool that we use. Now, Artem, you talked about working on this, so we'll be really excited to see what comes out of the college. This one is adapted from the International Patient-Centered Medical Home Commonwealth Safety Net initiative about 10 years ago. So it's gone through a Canadian adaptation and one that we use based on our high impact changes. The one that we're showing here, it shows you the distribution of the individual ratings that were provided by each of the team members on their own. Plus, after facilitation, then this is showing the consensus score in yellow that the teams agreed upon after they had a very rich discussion. These self-assessments inform team action plans so they can prioritize areas for improvement. On the right is the team huddle checklist that we use. And so teams of all models use this and tell us that it's a difference maker for them. We apply these concepts to all primary care practices, some small practices of just 2 people, the physician and the receptionist, to medium-sized practices and to large practices with dozens of people representing many disciplines. The goal is to optimize their roles and responsibilities for the shared population that they serve and move from being individual siloed staff to being an interprofessional team that reduces gaps, reduces duplication, while expanding to a comprehensive level of care. So there's so much evidence about the value of continuity. So we guide teams to understand their demand and supply so they can review their practice trends, analyze the demand that's coming from their patient population, and understand how they are allocating their team supply. So improvements can then be tested and specific work can be realigned to meet the panel's needs for access and continuity of care. So we know that a highly effective team has an awareness of and appreciation of each other's responsibilities and how it fits together. So the principles of the best ways to divide the work for an interprofessional team considers the highest scope of work of all professionals, the generalist versus specialist work, cross-training opportunities, as well as looking at a reduced fragmentation of care. So let's look at how a team can use these principles as an example. So they start by identifying who does and who could do each of the tasks. So based on the principles, they decide who will do the task. And in this case, this conversation tool that was used with the team shows with a green check mark their decisions about who will do the task. And the yellow check marks show which tasks they decided that a provider will stop or reduce doing so that they can focus on their priority responsibilities. So this will optimize the team's overall effectiveness. And this is an example of a conversation tool. It's not a reference tool. What's right for the distribution of work in one team will shift based on the context of that team. So we also help teams to create the visuals to see and understand their current ways of doing work and plan and prioritize improvements together. So the process map on the top left shows the typical steps that occur for a patient visit through this particular practice. The team cause and effect diagram that looks a bit like a fishbone there in the middle allowed each person on the team to give their ideas of why providers had so much paperwork after hours. And so after everybody had generated and organized their ideas, they chose a couple of those causes of the problem, and they chose to fix those and improve them. So, and on the top right is a pie chart showing the providers how much of their time is spent seeing patients on their panel versus seeing patients not on their panel, and how much time is administrative work and how much might be from other demands like hospital rounds or teaching commitments or other things. So teams can plan and work better together when they have this type of visual information. when teams.
Eileen, sorry, we're just after 1. So I'm just going to give you one more sentence, and we just want to leave a little bit of time for like 1 or 2 questions.
Absolutely, that the role of the practice improvement person is critical to helping teams to organize this information and keep it going. And so we really want to advocate for the change agent role within achieving these goals. Thank you.
Thank you. Thank you, everyone, for sticking around. We apologize again for our early technical challenges. IVO, do you want to pose a first question to the panels? We're going to stay on for like 2 more minutes to get a couple of questions in. There's been a great chat, so thank you for that.
Thanks so much to everybody. And this is just the hope that we had with all the chatter that we had within the chat as well, the opportunities for sharing. So that's great. There are a number of people that are on the projects here that are developing training for their own health professions. I'm just wondering from the panel, if you could identify what do you think is the 1 or 2 most important things that all of these training programs should consider embedding within their team primary care training programs to be prepared to work in a team-based model? Any thoughts? Carlene.
Actually, I had a question that I wanted to pose rather than an answer. So I don't have an answer, but I apologize if I have to leave to do an evaluation with a student quickly. But I'll save my question until later if I need to.
That's okay.
So Eileen, I'll just put you on the spot for the first one, and perhaps Lori or Angie might want to answer as well.
Okay, sorry. So sorry, Dale. I missed it.
Oh.
So Lori can answer. Sorry about that.
No, sorry, I missed it too.
The question was if you could identify 1 or 2 key unique skills that you think all healthcare providers, that many of the training programs are now designing to enable their healthcare providers to work in teams. What would you think is the most important things that they should actually put into the training programs?
Your question, Dale. Okay, I caught that. So sorry. So I would actually say that it is setting the conditions actually. So saying what's getting in our way, and really helping people to level set in terms of what their current issues are, and to say what are those barriers that we want to overcome together, because that what's in it for me. All of these programs, you know, we bring all these formal approaches, but helping everyone understand what drives them, motivates them, and what's getting in their way is really what's going to help the team succeed. And so taking it down to that experience.
Lori or Angie?
Yeah, I'm going to cheat and go back to our implementation elements, and right at the bottom there is the engaged leadership, because we can't get anywhere without having engaged leaders. So how do we build them? Maybe not directly into the training, but if we don't have those engaged leaders at the outset, we can never get to the next steps.
And I want to give a shout out, Arval, to my co-founder, in case you wanted to jump in too.
Yeah, and I think always what comes top of mind is ways to communicate in a very practical way. So some of the tools that were shared today around team-based huddles, an opportunity to really focus around what's in front of them each day.
Great.
Just to summarize, a lot of that is in there. So, and I'm looking at those competencies that many people are going to be looking at as well. Collaborative leadership, communication, negotiation. That's great. Dale, back to you.
Great. Are there any other questions before we wrap up? I think that I really want to thank the presenters, and thank you everyone for persevering with some of our challenges. In terms of the starting a little late, so appreciate you staying on a little longer. Judy, if you have a very quick question.
I do, yeah. It's more
up.
of, thank you so much. Judy King from University of Ottawa. I'm a Vice Dean of Interprofessionalism Partnerships and Practical Education. I think going forward, it would be really lovely if we get rid of the word allied health. It's my pet peeve because I'm never sure who we're allied to. I'm assuming we're all allied to the patient. So we are providers, other healthcare providers, or other, professionals, just to help level the playing field. So it's sort of help with that team base. Thanks so much. Really appreciate all the work.
Thank you so much. Thank you, everyone. Much appreciated for joining the Lunch and Learn. I just wanted to give you the heads up that the next Lunch and Learn is on April 26th at noon. And it relates to Indigenous reconciliation and how we move that forward in terms of integrating it into our training and into our teamwork. Thank you so much, everyone, for staying on, and much appreciated. Again, this will be also available by recording shortly. So thank you so much and have a lovely afternoon.